Welcome to the presentation, Who's Going to Make the Difference? The Role of Pharmacists in Addressing Disparities in the Management of Diabetes. My name is Scott Stolte. I'm the Dean of the College of Pharmacy at Roseman University of Health Sciences, and we have campuses in Henderson, Nevada, and South Jordan, Utah. The program is going to be divided into parts today. The first part of the program is I'm going to give you some background in diabetes and certainly establish some of the disparities that we're going to discuss. Hopefully this will be done in a manner that's interesting to you. It'll be highly graphical in nature so that you can see what is the extent of diabetes both in the United States and also in the world. In the second part of the presentation, I'm just going to give a brief overview of the newer classes of the medications to treat in specifically type 2 diabetes. And I'm going to focus on the newer medications that actually primarily treat postprandial blood glucose and talk about why is postprandial blood glucose important. Is it more important than fasting plasma glucose, and why or why not is that the case? And then in the third part of the presentation, I'm going to talk very specifically about what you as pharmacists can do to address some of the disparities that exist, and also thinking about the disparities in healthcare between individuals. What are the most important factors for that? For example, are socioeconomic status factors most important? Is it true that people who just have more money automatically receive better care? Or are there other factors involved as well? So we'll spend some time talking about that. And then at the very end of the presentation, I'll try to give you some very specific ideas about what you can do in your practice today or tomorrow to help to begin to address some of these disparities. Just as background, healthcare disparities have been recognized, and I'm going to use the term health and healthcare disparities interchangeably. There is a difference in definition, but for the purposes of this program, I'll use them interchangeably. Those have been known about in the United States at this point for well over 20 years. This just proves, though, that awareness doesn't always mean that things get better. In the case of health or healthcare disparities, it's actually gotten worse over time. Individuals who have disparities, actually who are lower, receive less care. That care has actually gotten worse over time, and people who are on the top end of the care has gotten much better. So the gap between the haves and the have-nots in health and healthcare has actually continued to get worse over time. So we'll talk about why that's the case and again, what we can do to address that. The objectives of the program: upon completion of the program, you should be able to evaluate the medication therapy and monitoring parameters of a patient with diabetes to ensure that he or she is being treated in accordance with current management practices and guidelines and meeting current treatment goals. Again, we're going to talk about some of the medications to treat diabetes, and we are going to talk about treatment goals. The number of patients or percentage of patients reaching their treatment goals is actually an area of disparity. Within certain populations, you have higher percentages of individuals who are not being treated to their treatment goals. Why is that? Well, it could be a number of factors. It could be with diabetes. The one thing that we know is no matter what medications a person is on, lifestyle modifications are important, perhaps equally important to the medications. There is a disparity in those lifestyle factors as well. But it could also be that people who aren't receiving the best health care may be less likely to be put on a combination regimen, so they may be less likely to achieve their blood glucose goals even from a medication standpoint. The second objective is to compare and contrast the treatment, complications, and outcomes for patients with diabetes with and without health disparities. And then third, as I mentioned, develop a plan to address deficits for your patients with health disparities. In terms of background, diabetes continues to grow worldwide. In fact, one thing that you may be surprised to learn that I'm going to cover in this presentation is the United States, while diabetes will continue to grow in terms of the number of people diagnosed with diabetes over the next 20 years, we will not be the fastest growing area of the world in the growth of diabetes. A lot of people think this is an American, United States, or even maybe a European problem, and that is in fact not the case, and we'll talk more about that later. But right now, in the United States, about 26 million people have diabetes. We're approaching that magic or infamous, I guess, 10% number where 1 out of every 10 people is diagnosed or has diabetes. The 25.8 million consists of about 18.8 million diagnosed and 7 million people who are undiagnosed. One of the surprising things to me, and maybe to you, is that we still have a significant number of people with diabetes who are undiagnosed. And one thing that really you can do as a pharmacist, I think, to help with this, and maybe some of you do this already, but I am astounded. We work with our students all the time to have health fairs throughout the city of Las Vegas and also Salt Lake City, Utah. What we find every one of those health fairs that we do, we find someone who has no idea what their blood pressure is, and their blood pressure is very highly uncontrolled. And we do glucose checks as well, and we have someone who has no idea what their glucose is and has glucose levels that are very highly uncontrolled. So I would encourage you in your pharmacies to either decide to or work with your company to decide to conduct these health fairs where you can provide screenings to patients and increase the awareness of these disease states. And I promise you, if you have a health fair and you can get members from the community to come to that, you're going to discover at least one person who, maybe if they don't have outright diabetes, has impaired glucose tolerance or impaired fasting glucose, or maybe if they don't have outright hypertension, they have blood pressure that's maybe a little bit higher than the goal that is established for that person. In addition to the 25.8 million people with diabetes, you have 79 million people with pre-diabetes, and that's impaired fasting glucose or impaired glucose tolerance, as I mentioned. The concern with those individuals is they're about 5 times more likely than a person without pre-diabetes to develop diabetes over the next 10 years. So that's an important population to know as well, and again, this is something you can discover on screenings and health fairs that you might hold at your pharmacy. 13 million adult men, and that's about 12% of all adult men. 12.6 million adult women, and that's about 11% of adult women. And you have 1.9 million new cases in adults diagnosed in 2010. So that's just new cases. This is not a condition that is going away. We're going to see more and more cases of diabetes over time. Moving on to the next slide, here's where we start to establish the disparities in the frequency of diabetes. And I think this is important to know. Not all races, racial and ethnic groups have diabetes to the same degree. So in non-Hispanic whites, what may be referred to as Caucasians, and I just wanted to take a minute to address the racial and ethnic designations that I'm going to be using throughout this presentation. I try to use the designations that are used in the studies that I'm reporting on. So if I say, Latino rather than Hispanic, or non-Hispanic white rather than Caucasian, or African American, African black, those are the designations that were actually used in the studies that I'll be talking about. So don't think that I am making those designations, and I apologize ahead of time if anyone is offended by any of these designations, but I'm just reporting what was actually used in the studies to be most accurate. So in terms of racial and ethnic differences in the prevalence of diabetes, as you can see, non-Hispanic whites or Caucasians have about a 7% prevalence of diabetes. What I think surprises many individuals is the prevalence in Asian Americans is actually even higher than in non-Hispanic whites. When you think about the populations that have type 2 diabetes or diabetes in general, people tend to not think about Asians or Asian Americans, and certainly there is a difference between Asians and Asian Americans. But I think as we get later to what's happening worldwide, I think you might continue to be surprised. So Asian Americans are about 8.5%. Non-Hispanic blacks are about 12.5%. Hispanics are around 12%. And then Hispanics are further divided into Cubans, Mexican Americans, and Puerto Ricans. And you can see with Puerto Ricans, the percentage prevalence increases to almost 14% of the population. So when we start to think about who are the people that have disparities, we can start first to think about racial and ethnic groups and even disparities in prevalence. Now, what leads to those disparities in prevalence? Well, there are many factors that are probably linked. There are educational factors, there are socioeconomic factors, there are health literacy factors, and we're going to talk a lot about health literacy a little bit later. So there are many, many factors that lead to that, but I think it's important for you to know where you start. Why is this important as a pharmacist? Well, as I'm talking to you in this presentation, I want you as a pharmacist to think about the community in which you live. So, for example, maybe you're in a community that is almost entirely non-Hispanic white. So you know in that community about 7 out of 100, every 100 patients that you see has diabetes. How many of those people are receiving the optimal possible care? Are there any disparities even within those populations? If you live in a community where a great percentage of the patient population is Hispanics, then you already know that about 12 people out of every 100 of those have diabetes. Well, how many of those people are diagnosed versus undiagnosed? Is there anything that you can do as a pharmacist to help discover those undiagnosed patients? Is there anything that you can do as a pharmacist to help treat those patients better? So I want you to bring this whole presentation, I want you to continue to bring it back to the practice setting that you're in and apply what I'm talking about to your practice setting and think about what can I do to help address the patients that I have. In terms of morbidity and mortality, as you can imagine, diabetes is a disease state that causes tremendous morbidity and mortality. As you get to deaths, in 2007, diabetes was pinpointed as the primary underlying cause in about 71,382 deaths in 2007. So that's diabetes as the primary cause of death. When you add into the fact those where diabetes was a contributing factor, meaning it may not have been the underlying cause, but the diabetes played a role in other disease states that may have been the primary cause, that's another 160,022. So diabetes played a role in 2007 alone in 231,404 deaths. In terms of costs in 2012, diabetes is an expensive disease state, primarily because it can lead to some fairly severe disability. For example, you might be aware that diabetes is the leading cause of adult blindness. Well, certainly individuals that do become blind have costs associated with their living, costs associated with their care. Diabetes is the leading cause in adults of non-traumatic amputation. Certainly individuals with amputation have difficulties in their care. So as you can imagine, those things are quite expensive. So in terms of cost, the total cost of diabetes in 2012, and this is just diabetes, was $245 billion. Of that, $176 billion was direct costs. Direct costs are those tangible costs of care. For example, a hospital admission is a direct cost, the cost of that hospitalization. Costs of medications are a direct cost. Cost of durable medical equipment, wound care, walkers, wheelchairs, those are direct costs. In terms of lost productivity, it's almost another $70 billion. So that would be costs associated with missed work days, costs associated with missed school days if an individual is still in school, costs associated with missed appointments. So those are the indirect costs, or productivity costs, are also very high. And for individuals with diabetes, in general, they're going to spend about 2.3 times more per year than individuals without diabetes. So if you think about the cost for a person without diabetes as compared to with diabetes, the person with diabetes, for every dollar that a person without diabetes spends, the person with diabetes is going to spend $2.30. As you can imagine, on the scale of 1,000 or 10,000, that adds up pretty quickly. So diabetes is an expensive disease state, both from a productivity standpoint, but also a direct and indirect medical cost standpoint. I'm going to make a small transition here away from kind of prevalence and background to more epidemiology. And when I started the program, I told you that you may be surprised a little bit by what's happening with diabetes worldwide. And I wanted to touch on that here. So this is what you're looking at is a map of cases of diabetes. And what it is the number of cases of diabetes in 2000, the year 2000, and the number of expected cases of diabetes in the year 2030 based upon what's happening right now. And just take a look at the different areas, and you can see that while the United States from the year 2000 to 2030 will approximately double in the number of cases of diabetes, look at regions like the Middle East, Africa, for example. The Middle East is a great example. In 2000, there were about 15.2 million cases of diabetes. In 2030, there will be about 42.6 million cases. So rather than doubling like the United States, that will actually triple in terms of the number of cases of diabetes. And I just find that fascinating because I think most people believe that this is, as I mentioned, a United States, a European problem based primarily on the fact that we indulge in the foods that we eat, and that's just not the case. And you can see the top 10 countries worldwide in terms of the number of people with diabetes are India, China. I think that surprises a lot of people that China would be there. The U.S., Indonesia, Japan, Pakistan, Russia, Brazil, Italy, and Bangladesh. And so in terms of diabetes, it may not be the countries that you would have, if I had asked you before this presentation started, where is diabetes localized? I don't think people would list a lot of those countries that are on the list, especially in terms of the growth. On the next slide, you can see it just formatted and presented a little bit differently by the percent increase in diabetes that will occur, again, over the next 30 years from 2000 to 2030. And you can see some of the percentages. As I mentioned, the Middle East increasing by 164%. Southeast Asia, which may be one that you didn't expect at all, increasing by 161%. United States increasing by 72%. Europe increasing by only 32%, smallest increase in the world. I would bet that some of you might have thought that Europe would be among the fastest growing, if not the fastest growing, in terms of percent increase in diabetes. So this gives you an idea in terms of the disparities in growth of diabetes worldwide. Now, what causes this? To what can we attribute this to? I think it has to do a lot with kind of the migration of Western diet, Western habits across the world, and embracing that Western lifestyle. That certainly it has a role. There are actually genetic factors involved in racial and ethnic groups that make them more likely to develop diabetes. There's a lot of factors. But the bottom line is I wanted you to be aware of this so that you can see just exactly what we're dealing with, that diabetes is not just a problem of the West, that diabetes is a worldwide problem at this point, and that the problem is actually going to continue to grow more and to a greater extent in the non-Western populations over the next several years. Estimated lifetime risk of developing diabetes for individuals born in the United States in the year 2000. And you can see that, so what we're really talking about here is individuals at this point that are about 13 or 14 years old, and what is their actual risk of developing diabetes. And I wanted to point this out, certainly to show the difference in racial and ethnic groups. As you can see, if you compare, the risk is highest in Latino or Hispanic populations. But what I wanted to also show you is I think many people, when they think about diabetes and diabetes risk, think of this as primarily a disease state of men. And I don't know how that has actually developed, but I did want to take some time to show that actually the very highest percentage in terms of developing diabetes in individuals born in 2000 is among Hispanic women, even greater than that of Hispanic men. And as you can see across the different disease states, diabetes is becoming more and more, especially type 2 diabetes, a disease state of women, even over that of men. So again, another kind of misconception, another disparity that I think it's important for you as pharmacists to recognize. So while maybe we focused a little bit more on the growth of diabetes in men in the past, we should certainly think about how do we address this problem in women? How do we get women to think about this? Because that's an important population. Moving on to the next slide, the rate of new cases of type 1 and type 2 diabetes among youth aged less than 20 by race and ethnicity 2002 through 2005. And what I wanted to show you here is really, first of all, this, if you look at this graph and think about what it means, it should be absolutely startling to you. So if you have 2002 on the left-hand side, 2005 on the right-hand side, you'll see that the darker bars are much, much greater in 2005 than even in 2002. What those darker bars are is the cases of type 2 diabetes increasing even in those 3 years, and this pattern has continued. There's some smaller studies that showed what type 2 diabetes is happening right now, but type 2 diabetes is increasingly becoming a disease of adolescence, not adulthood, although certainly it's a disease state of adulthood as well, but increasingly a disease of adolescence. This is a sad state of affairs. So as you're thinking about what can I do as a pharmacist, most of the patients that you see are going to be adults. But I want you to start thinking about what can I do for the adolescent populations in my community. Specifically, and as you can see on the bottom there, this is also broken out by racial and ethnic groups as well. So you see the different racial and ethnic groups that are at risk. On the far right, when you look at American Indian population, Native American, again, not getting caught up in the what we call these individuals, that is a population in tremendous need. So if any of you out there have the opportunity to work regularly with American Indian or Native American populations, please think about what you can do to focus on those young patients to increase their awareness of diabetes, to increase their care, to change their lifestyle, to change their habits, so that this great increase in the development of type 2 diabetes, even among the young of that population, does not continue. And you can see, again, take this information, apply it to your locality, apply it to the practice that you're in, and think about what can I do to assist with this. Okay, getting to the glycemic goals for adults, it can be a little bit frustrating with goals because there are some differences. Most of us are probably going to accept the American Diabetes Association goals for both hemoglobin A1C and blood glucose. Just keep in mind that the American College of Endocrinology, the American Association of Clinical Endocrinologists, and even the World Health Organization have some different goals. The American Diabetes Association goals tend to be the least aggressive of all the goals. So ADA goals for diabetes, hemoglobin A1C of less than 7%, that's probably the number that you're most familiar with, that you've heard the most. Pre-prandial plasma glucose of 70 to 130 milligrams per deciliter, so that's the fasting goal. And postprandial plasma glucose of less than 180 milligrams per deciliter. And I want to point out that that 180 number really is an important number at this point. People that have very difficult to control or very out of control diabetes, they tend to have more fluctuation in their postprandial glucose number than they do in their fasting glucose number. And as I mentioned very early in the program, the focus at this point really in the overall care of diabetes is on the postprandial blood glucose or the non-fasting glucose. The postprandial glucose actually has a greater impact on hemoglobin A1C than the fasting glucose, and there's quite a bit of data at this point to show that the postprandial glucose, the post-meal glucose, has a greater impact actually on the disease control itself, the complications of the disease. So in the past, I think as pharmacists, as healthcare professionals, we've really thought primarily about controlling that fasting glucose number, encouraging patients to measure that number. We want to get away from that. Really encourage patients to sometimes take a fasting glucose number, but really focus on that postprandial or random glucose number because it probably is the more important of the two. Also, for those of you who are involved in diabetes care regularly, as I am, you may be familiar with patients that have wonderful fasting blood glucose numbers, just absolutely rock solid control of their fasting glucose, but their postprandial glucose is totally out of whack. Well, that is not a well-controlled patient. So as a pharmacist, think about, I have patients, they're not going to test more often than once a day. The cost of the strips are too high. What do I do? Or they're only testing every other day because of the strips or what have you. What should I recommend to that patient? If a patient is testing once a day, what I would recommend is 2 fasting tests per week, but then the rest of the days be what I would refer to as random. So after a couple hours after meals, maybe 6 hours after a meal, just to get a picture of where that person is throughout the course of their entire daily cycle, rather than pinpointing and focusing on that fasting glucose. You do individualize goals at this point. There have been several studies. Not every patient should be controlled on what's called tight control. We want to give some ability of patients not to be tightly controlled. And if you want to know more about that information, you can look at trials like ACCRED trial, which actually showed that if a person has had long-standing diabetes and they're older, that tight control may actually be harmful for them. And I won't spend a lot of time there. You can see some diabetes screening recommendations, and I don't want to cover this in terms of the presentation, But all I wanted to say is please engage in screening, please engage in health fair type activities where individuals can get their blood glucose tested. You will find people who need additional care. All right, so let's transition over to the medications that are associated with diabetes and spend just a little bit of time there. When you look at on the slide that shows all of the different medication classes, I've bolded the ones that I'm going to cover in this presentation just very, very briefly, because I think that it's important that we cover those because they're newer agents and they work a little bit differently than some medications that we've had in the past. So as I talk about the drug classes, you can actually see where it is that these drugs work. But most of the drugs that I'm going to highlight for the purposes of this presentation do kind of the same thing. They focus on postprandial blood glucose primarily, and they have effects on the GI that are highly beneficial, GI tract that are highly beneficial for diabetes. So let's focus first on the amylin analogs, and the drug is pramlintide, which is Similan pen. What it does is this mimics the action of amylin. So what that does is it suppresses high postprandial glucagon secretion. And what you may have heard that referred to as inappropriate glucagon secretion. The blood glucose is already high, but because of the relative deficiency of insulin, the blood glucose is actually not able to get into the cells. So the body thinks that the blood glucose is still low since glucose is not in the cells. So what it does is it makes more glucagon to break down the glycogen into more glucose. So it actually causes the problem to get worse. We want to prevent that. We want to prevent this inappropriate glucagon secretion. So it suppresses high postprandial glucagon. It increases satiety, so it causes a person to feel more full, more satisfied, so they don't eat as much, they don't take in as much glucose. And it delays gastric emptying. It's going to cause the food to remain in the GI tract for longer. Thus, you have a more gradual absorption of blood glucose from the GI tract rather than a rapid dump of blood glucose into the bloodstream from the GI tract. So all of those things are beneficial. Those three activities, the suppressing the inappropriate glucagon secretion, the increasing satiety, the delaying gastric emptying, for many of the drugs that we're going to talk about, that's the primary mechanism today. You can see some fairly benign adverse effects with the exception of the nausea. In terms of efficacy, the amylin reduces hemoglobin A1C by about 0.3%, reduces postprandial glucose primarily. It doesn't do a whole lot for fasting glucose, but reduces postprandial glucose. You may have seen patients actually use Similan pen to reduce the insulin requirements, and that's a common use. However, co-administration with insulin can lead to some pretty severe hypoglycemia. So that's the amylin. The next drug class I want to talk about is the DPP-4 inhibitors, or the dipeptidyl peptidase 4 inhibitors. These are drugs that you're probably very familiar with from their trade name, but you may not be as familiar with how they work. They include sitagliptin, which is Januvia, saxagliptin, which is Onglyza, linagliptin, which is Tradjenta, and alogliptin, which is Nesina. Mechanism of action, they prolong the half-life of a hormone or protein called GLP-1 and also GIP. They block the activity of the DPP-4 enzyme for at least 12 hours, so this prevents the breakdown of GLP-1 and GIP. So really we're relying on increased beneficial effects of GLP-1 and GIP. So what are those beneficial effects? Well, they're almost exactly the same that we just talked about for amylin. They reduce glucagon secretion, they increase glucose-dependent insulin secretion, and they slow the gastric emptying. So very, very similar in terms of effects. Adverse effects with DPP-4 inhibitors, as you're probably aware, the reason that these drugs have become so popular is that they're very benign in terms of adverse effects. In terms of hemoglobin A1C reduction, you get fairly good hemoglobin A1C reduction, 0.7 to 1%. They reduce primarily postprandial glucose, same as amylin. You do reduce saxagliptin dose in the presence of cytochrome P450, 3A4, 5 inhibitors, and do not use in patients with a history of pancreatitis. Then you have, instead of actually preventing the breakdown of GLP-1, you have a class of drugs that actually serve as GLP-1 agonists. So they act just like GLP-1, as you can imagine, producing the GLP-1 beneficial effects. And those include exenatide, which is either Byetta or Bydureon, and liraglutide, which is Victoza. Mechanism of action of these, and by the way, as I'm sure you're aware, these are injectable products, not oral. They bind to the GLP-1 receptors. They increase glucose-dependent insulin secretion, decrease that inappropriate glucagon secretion, slow gastric emptying, and increase satiety, which decreases food intake. With these drugs, the primary adverse effect that you're probably used to hearing about in patients who have taken Byetta, in patients taking Bydureon, and now Victoza, although it appears Victoza may be a little bit less, is the nausea. So nausea can be a significant limiter for these particular drugs. There are some other adverse effects as well. In terms of hemoglobin A1C lowering, very effective. They can reduce hemoglobin A1C by 0.5 to 2%. They primarily lower postprandial blood glucose, as we mentioned. Exenatide, immediate release, you have to take into account meals. The extended release, the Bydureon, you can administer without regard to meals. And Victoza is also without regard to meals. One thing that you're probably familiar with these drugs is their effect on weight. These drugs do cause weight loss. That's a beneficial effect for most patients. And the weight loss typically is somewhere in the neighborhood of 2 to 5 kilograms depending on the individual. So upwards of 10, 11, 12 pounds can be caused and actually maintained. And that's actually the really great thing about these drugs. The weight loss that they cause, so long as the person remains on the drug, is actually maintained over time. And then the newest class, or the newest drug that I just wanted to talk about very briefly, are the sodium glucose cotransporter 2 inhibitors. And there's only one drug in this class at this point, trade name Invokana, and it's canagliflozin. And the mechanism of action is, it's complicated, but essentially, if you think about what happens in the kidneys, glucose can actually be reabsorbed from the kidneys back into the bloodstream, so thus causing the blood glucose to go up. This prevents that reabsorption, actually causes that glucose to be eliminated, and thus keeps the blood glucose lower. So it inhibits the sodium glucose transporter in the proximal renal tubules, which reduces the reabsorption of glucose, causes that glucose to be excreted. That increased renal excretion of glucose is going to cause a relative lowering of blood glucose. There are some adverse effects associated with that I'm not going to spend a lot of time on. This particular drug can reduce hemoglobin A1C by 0.7 to 1%, focus primarily on postprandial blood glucose. It's recommended to take it before the first meal of the day, and there are some drug interactions as well. So again, when you think about these newer drugs, overall, what I want you to remember is the focus is primarily on postprandial blood glucose, not fasting glucose, and these drugs are meant to be used in combination. For type 2 patients, as you're probably aware, unless there is a contraindication, metformin is the drug of choice still. So these patients would be added on to metformin in patients who can tolerate metformin, or added on to another type of drug in patients who cannot tolerate or cannot take metformin. All right, for the rest of the time, about the next 14 or 15 minutes, we're going to really focus on these disparities, what causes them, what can we do as pharmacists to address them. And one of the questions that I always have about this is, or one of the comments is, I would love to do this for my patients. I'd really love to address these disparities, but I'm just too busy in the activities of pharmacy. And, the pharmacy company that I work for, whether it be chain pharmacy, hospital, they don't incent me to do these things. They incent me, or they want me to focus on volume, on prescription filling. When is that going to change? And as a fellow pharmacist, I want to say to you, I know that. I know that you're being asked to, to focus on volume, to focus on prescription filling. And, I too ask the question, when is that going to change? Well, that change may in fact be on the horizon, and some of you may be familiar with some of the changes that are occurring in healthcare. But one important, I think, driver of this change is the pharmacists achieving what's called provider status, and you may be familiar with this. What that really means is that pharmacists currently in the Social Security Act are not considered healthcare providers, and thus they're not recognized as providers under Medicare Part B. So pharmacists cannot get paid or reimbursed for your typical care type activities. Well, a number of different pharmacy organizations, that includes NACDS, the National Association of Chain Drugstores, the American Society of Health System Pharmacists, American Pharmacists Association, APHA, NCPA, they recently united to form a group called the Patient Access to Pharmacist Care Coalition, PAPCC. And what that coalition did is they've actually at this point introduced legislation in the form of HR 4190 that is intended to amend the Social Security Act to recognize pharmacists as providers under Medicare Part B. Now, has this been tried before? Yes. We've tried to introduce legislation before that adds pharmacist provider. The difference this time, and a very key difference for most of you, is that NACDS has become involved. NACDS represents chain drugstores. They have very significant financial resources, very significant lobby. Typically, what NACDS wants to happen in the pharmacy world actually does happen. And so, with NACDS's backing in the PAPCC, this is bipartisan legislation. It was actually introduced by 2 Republican representatives, Brett Guthrie from Kentucky, Todd Young from Indiana, and by 1 Democratic representative, G.K. Butterfield of North Carolina, that will amend the Social Security Act. So will this be successful? I don't know. I don't know at this point if it will, but this is a significant step. So, bringing this back to disparities, I do believe that there will be a time where pharmacists are financially incented to do things other than just focus on filling prescriptions. And even some chain pharmacies, and certainly within health system pharmacies, models have been changed, dispensing models have been changed to allow pharmacists to focus on this provision of care to patients. And that's really what we need. We need a focus on the provision of care rather than on the commodity of product to get pharmacists to do some of these things that we're going to be talking about. Now, with that background, let's talk specifically about disparities. So what are disparities? Disparities are variations in the provision of healthcare to people with different backgrounds and characteristics, and that can be race, ethnicity, socioeconomic status, etc. And what leads to these disparities? It can be social factors, economic factors, poor disease management, different environmental conditions, lack of health resources. Just to give you a couple of examples there. For example, asthma as a whole tends to be worse in people that live in urban environments than it does in rural environments. And that may surprise you because you think, well, rural environments might be dirtier, there might be more allergens, whereas the urban environments might be cleaner. And that's actually the point. Something called the hygiene hypothesis with asthma that really is leading us to the cleaner people are, the more we focus on things like antibacterials, antiseptics, actually the more asthma develops, and it's probably because they don't have enough development of IgE, which occurs due to these exposures to different antigens. So that's just an example of a disparity. What are the drivers of disparity? What is the real force behind? What are the factors that really lead to these disparities? Lack of insurance is one. Poverty is another, and racial and ethnic group is another. These are the big ones. These are the ones. So thinking as a pharmacist, what populations do I want to focus on to address these disparities? These are the big populations. Do you have a significant number of patients who are uninsured? Do you have a significant number of patients who are at the poverty level or below? Do you have a significant number of patients that are in any of these racial and ethnic groups? If you do, you can do something about disparities, and I would encourage you to do so. In terms of the uninsured, you can see the makeup of uninsured by racial and ethnic population. In terms of the diabetes care, uninsured are less likely to receive routine glucose monitoring, eye exams, foot exams. They have increased hospitalization risk, and they have increased risk of chronic disease and disability. And that's uninsured. What about poverty? Poverty is the greatest percentage of the uninsured. 40% of people earning less than $10,000 a year are uninsured, as compared to only 7.1% of those earning more than $75,000 a year. And you can see the different poverty rates by the racial and ethnic groups listed there. So do I have these populations? What can I do? And then I go through the different racial and ethnic groups, and I'm not going to take a lot of time on these, but I just want you to know that of the racial and ethnic groups that I've listed there, African Americans, Hispanic Latinos, certainly American Indians and Alaska Natives, all of those racial and ethnic groups are less likely to have optimal care. They're less likely to receive things like annual hemoglobin A1Cs. They're less likely to monitor their blood glucose. They're less likely to have foot exams. They're less likely to even have a primary care physician. So the racial and ethnic groups are a big driver of disparities in healthcare. So think about what can we do about that. Moving on to what I feel is a very important factor in this is health literacy and numeracy. Health literacy is the ability to understand, engage, and actively apply health information to improve one's health. And numeracy is the ability to understand and use numbers in daily life. Low health literacy is more prevalent in racial and ethnic minority groups. 41% of Hispanics have low health literacy, 24% of African Americans, and 9% of non-Hispanic whites. Adherence is something that we as pharmacists, we absolutely should take ownership of. We need to focus on getting our patients to take their medications. And there are many, many ideas for that. And I would encourage you to share your adherence ideas in the chat box so that others can see it. What have you done that has actually caused your adherence in your pharmacy to be successful? But poor adherence is associated with poor disease state outcomes, and that's true for diabetes as well. There are racial and ethnic disparities in adherence also. An interesting trial that I just wanted to cover briefly is a trial by Osborne, and they tested whether health literacy and numeracy were related to medication adherence and whether either factor explained the racial and ethnic differences. So they had 398 patients. 35% of those patients were African American. 31% had low health literacy. 69% had low health numeracy. And the mean hemoglobin A1C was 7.6%, so the mean was not at goal. Some interesting results here. African American race was significantly associated with less adherence. Low health literacy had a direct effect on adherence, so the lower the health literacy, the lower the adherence. The numeracy was not related to medication adherence. Health literacy reduced the effect of race on adherence to insignificance. What that means is that once patients were normalized for health literacy, the race factor disappeared. So this raises a very important question, and that is, does health literacy actually explain the difference between racial status and adherence? And I think the answer may be yes. So rather than focusing on just a patient's race, what we really should be focusing on is this patient health literate? If I give them some information about a medication, can they actually understand it? We need to be assessing that as pharmacists. And again, I know you may say, I don't have the time to do this. Well, I can tell you one thing. If you're relying on the information in terms of a monograph that's given to a patient to provide them with information, your patients are not going to understand it. The reason for that is that the average health literacy of a patient in the United States is about the 7th or 8th grade reading level. Those monographs that we hand out and put in the bags as pharmacists, maybe even go over them with the patient and say to the patient, read this when you get home. On average, those are written at anywhere from the 10.5 to 12th grade reading level. That is well above what most of our patients can understand. So what can we do about that? We need to address our patients. We need to figure out where are they on the health literacy scale, and we need to address them where they are. If they're not able to understand what we're giving them, and that's as easy as saying, please read this and tell me about it. Please read the directions on your bottle and tell me how you're going to take this medication. If you give them the bottle and they read the directions and they can't tell you how they're going to take it, what that probably means is that their health literacy, it does not allow them to understand the directions. So you need to adjust it. You need to put it on their terms so that they can. So let's take the last couple minutes to say, what can pharmacists do to address health disparities? And I've talked a little bit about this already, but I want you to be clear that I do understand this. I still work in retail pharmacy, some, not regularly, but some. And we all know the barriers. The barriers are no time, no recognition, no or very little support, and no reward. And these factors don't seem to be getting any better, and that is frustrating. You're probably all aware that the amount of support, technician support, within pharmacies has gone down over time, and really even with the recovery of a lot of the volume and the economy of pharmacy, the support has not risen back up to the point that it was prior to the economic downturn. We're aware of that. However, what I want you to know is every healthcare provider, physician, nurse, PA, they all cite the same barriers. So if everyone is citing the same barriers and we're not taking care of the patients, who is going to do it? Which healthcare provider is finally going to say, I am going to address disparities. I am going to address health literacy. I am going to address the care of these patients. I want it to be pharmacists. We just have to figure out how can we do this. And I think as we get toward a model where incentives are based on the care of patients rather than on the delivery of the drug product, that we may be in a position as pharmacists to provide this care that can really affect these things for the first time. I want you to be practical also. Sometimes in presentations like this, individuals say, I can't possibly do this for every patient. I'm not asking you to do it for every patient. In fact, I'm not asking you to do it for most of the patients that you see. Not every patient that you see needs this type of intervention. Certainly not every patient wants this type of intervention, and we're not going to force them. But there are patients who want this, who need it. How many of those do you have per day? My guess is that it's probably a few. 10 maybe at the most, 1 or 2 maybe at the least. So are we trying as pharmacists to identify who are those patients who need this increased intervention? Who are the patients who want this? I will say, when I'm in a busy pharmacy, functioning, getting my duties done, one of the last things I'm thinking of is which patients really need my care? Which patients need me most as a pharmacist? I wish I was thinking about that more because I think it's tremendously important to think about. So what I'm asking you to do is the next time that you work, the next shift that you have, take the time to try to notice, is there a patient throughout the course of the day that really needs my help, that needs my care, that doesn't seem to understand, that isn't adherent time and time again. They're always late. They don't understand. They never seem to get their refills on time. Their disease parameters are not good. Their glucose it doesn't seem to be under control. What can you do for that patient? So it may be thinking big picture. Is there something about the workflow at your pharmacy that prevents you from having time for those patients? Is there something about how you utilize technicians or interns? And I'll tell you, one of the things that I wish that I could deliver just in the clearest possible way is please, please, please think about how pharmacy students can benefit you. Remember, pharmacy students as interns in almost every state, in fact, it may be every state, function as agents of the pharmacist. They can do everything that a pharmacist can while they're under pharmacist supervision. Utilize student pharmacists. If you don't have them now, bring them in and think about how can I utilize these student pharmacists so that I can spend more time actually caring for patients. Think about who your patients are. We've talked about a lot of areas of potential disparity today. Do you have any of those patient populations? Does your pharmacy serve a large demographic of African American patients? If so, start to talk to those individuals about what specifically can I do as a pharmacist to help this population address unmet healthcare needs. Go to community centers and ask. Community centers see patients in bad health condition. Ask the staff at the community center, what can I do as a pharmacist to increase the health of these people? And then, bottom line is start with one person. One person, the first day that you're at work after hearing this presentation, help them. Genuinely help them. Address the needs that they have. Try to produce a better outcome with them. I want pharmacists to think in terms of public health. Think about lifestyle changes. Very few people are taking the time to address lifestyle changes. As I mentioned earlier in the program, I want you to think about health screenings. And this is not just community pharmacists. As hospital or health system pharmacists, provide these screenings, provide these health cares. And like I said at the very beginning, you are going to be amazed. You are going to find patients who are out of control and had no idea that they had any kind of problem at all. And for these patients, when they're identified, provide self-management information and training. Some of you are probably very familiar with this, but I see patients all the time who have this blood glucose meter and, number one, may have never used it. In fact, they might not have taken it out of the box. But when they do use it, the technique is not correct. It's all wrong. It's probably because they've never had training. And I can tell you they're not going to get that kind of training from any other healthcare professional. We as pharmacists really need to own that. Think health literacy. So think public health, think health literacy. Do my patients really understand the information that I give them? Do I make assumptions about what they know? When I give a patient a vial, do I automatically assume that they can understand the directions that are on that? For most people, that answer is going to be yes, and that answer really shouldn't be yes. Many patients are not going to understand that. How do I know? How can I check to make sure they understand? How many of you ask the patients to repeat the directions back to you? Very, very important. We should be doing that almost with every new prescription. Think adherence. Adherence is a big area of focus. Are my patients adherent? Do I know? Have I looked at a patient's records to see, are they getting their refills as scheduled? If not, why haven't I looked? And what can I do to improve adherence? And finally, I want you to just think care. Do I really care about my patients? When a patient walks in the door, do I look at them as a person, or do I look at them as the vials that they're about to drop off, or as the number of pieces of paper that they're about to hand me, and think about the amount of work that's going to go into filling those? We need to start thinking about our patients as people. What can we do to improve their overall care and lifestyle rather than just the medications that they're taking? How do you show your patients that you care? And what difference could I make if I truly cared for one new patient per day? And that's what I'm asking. In this presentation, that's the take-home message. I want you as a pharmacist, for every day that you work a shift or work some time, to identify one patient per day that you can help, that you can really truly spend time with and address and produce better outcomes in that patient. And with that, I'd love to take some questions. I'm sure there will be some questions and comments that you all have. I appreciate you listening to this presentation. Please use the chat box area for ideas that you have, for interventions that you've made that have helped your patients, and to submit questions.